Welcome to the series on adapting to age-related changes in the home, day program, and community. Successful aging requires that all of us recognize and adapt to changes that naturally occur to all of us. Adults with intellectual and developmental disabilities experience the same changes, although some may experience them at an earlier age. Adaptations to the home, work, or day program are often needed to promote quality of life and safety, and prevent loss of daily functioning. In addition, we can work with community organizations and businesses to ensure that people with IDD can take full advantage of resources that promote inclusion and quality of life. Community partners and service providers may need to work together to build bridges and learn how to best accommodate the needs of adults with IDD who are aging or who have dementia. Adapting the residence for aging adults with intellectual and developmental disabilities. This is one webinar in a series of webinars that address making adaptations to accommodate the changes that come with caring for an aging adult with intellectual and developmental disabilities. Throughout this webinar, we'll talk with Mary Jo Cooper, Vice President of Developmental Disability Services for Bay Cove Human Services. She currently runs residential, day, and family and independent support services throughout Greater Boston and the Southeast region. We also have Dottie Farrell, who is the Director for Health Services for Bay Cove's Developmental Disability Services. She provides health care and administrative leadership in the operation of Bay Cove's community-based services to adults with developmental disabilities.
I think the most important thing is to know who the person is, what's important to them, what they're used to, and then know what their trajectory is. So you want to make sure that the environment is physically safe, you want to make sure that it's emotionally safe, and you want to make sure that it's accessible.
And in so doing, making it safe for the person, we also have to make it safe for the staff, because you can't create something that they can't work with for the individual.
You have to know and respect each person as their own person, or else it doesn't work.
Like all aging adults, people with IDD have the right to participate fully in their communities. They face the same choices as anyone about retirement, leisure activities, and healthcare decisions. It means that, where possible, people with IDD have the choice to age in place. In other words, stay in their homes rather than moving to more restrictive settings. With proper support, many people will be able to live safely, comfortably, and with dignity at home. Hospice, when indicated, may allow some people to remain at home right to the end of their lives. A typical decision for elders with IDD, as with most elders, is about whether and when to retire. Often that decision arises from the desire or need to retire from typical day program attendance. An individual may not have the stamina for a full day program, so other options for meaningful participation need to be considered. Some options include attending a day program designed for elders, or perhaps attending a memory cafe run by a church or community aging center. They might be better options rather than a program geared towards employment. Often these programs will have shorter hours than typical day programs. When planning for someone's retirement, pay special attention to changes to the residential staffing needs, as well as using appropriate funding sources. Consult with your area office on this. You will also need to find appropriate community activities for the person to engage in, and ensure ongoing relationships with housemates and friends. A flexible schedule that can react to a person's health and stamina needs must be thoughtfully considered. In many instances, retirement is a planned event, and as such, planning discussions should start well in advance and should be part of an individual's ISP meeting. Ongoing team meetings are important to keep all informed of the person's wishes. When a person retires, residential staff may find themselves more involved in and responsible for assuring that the individual becomes involved with other activities in the community. There are many options available that can help people stay engaged in their communities, and we'll talk more about this in other webinars. But some resources to consider include senior centers, memory cafes, transportation, aging and disability resource consortia, and adult daycare programs. Look for related webinars on our website. For people who are frail and homebound, look for community services and activities that can be brought into the home to facilitate a meaningful day. You may find local musicians who will come in to perform. Religious groups may provide home visits. Often volunteer agencies have people who can serve as companions or to lead activities, games, art, conversation, and volunteers who can bring in companion animals for visits. Beyond everyday grooming and hygiene, housebound elders may want their hair kept looking nice, and salons are able to send in hairdressers to work in the home. See what interests the individual, and seek out volunteers or businesses who can provide services in the home.
We partner with people. We partner with people to know what they're looking for, know what's important to them. We partner with people to find out what in the community is important, what they think about end of life, what they think about big decisions like end of life, and the little decisions like what do they want for dinner, how do they want to spend their leisure time. We need to think quite a bit about our resources and how to balance that with what people want. And then we get creative and try and really work with the community to see what the community can bring to us.
And again, it's training of staff, because sometimes staff think, when those terms, they think of what's important to them or what would be important to them, and trying to gear them back into the individual.
Right.
For all aging adults and their families, decisions about where to live are among the most difficult decisions to make. It's a common assumption that very aged people need to move to a nursing home, and yet most people would rather avoid that. The policy of the Department of Developmental Services is to help people stay in their own homes as they age and avoid moving to a nursing home as much as is possible. Often, this will involve modifications to both the physical environment as well as staffing supports. And as mentioned previously, hospice services, when needed, allows a person to remain at home even until the very end of life. Discuss arrangements and any financial details with the DDS area office beforehand.
Safety measures would be certainly lifts to help people out of bed or get them into wheelchairs, and it's not just helping the person, again, it's also helping the staff. Grab bars in bathrooms, shower areas. Oftentimes we think of grab bars after someone has already fallen, and then we realize we need to get more equipment in there.
I would say also some minor, not quite as big stuff, but lighting. We need to reevaluate lighting, where the lights are, how many lights you have, what's on the floor, clear pathways, especially as people's vision changes and their gait changes. You want to make sure that you have a wide enough pathway for people to navigate, not have a lot of throw rugs, have the right, make sure that the floors aren't wet, that when people are out and about walking, that you want to be just more cognizant of the physical environment.
Lighting is such a big deal. Often in group homes or even in day programs, the flooring is not rugs, it's linoleum and it's shiny.
Mm-hmm.
So that even can be very difficult for people to navigate. And if you don't think of that, you begin to think that they're having behaviors. They're not having behaviors. They're reacting to the environment, and they're perhaps frightened.
You also want to consider noise, all the sensory stuff. Again, I think you want to be really cognizant of each person and what they like, what's important to them in terms of food. And some people, food is one of those daily pleasures, and other people it's not. So you want to be able to manage that and manage the meal time in a way that is accessible for every person. So if somebody gets overstimulated by a lot of chatter, they may not want to eat with people. although you want the community piece. So you have to really be thoughtful about those things and helping people make the decisions that's going to maximize their interactions and their connection. You want to be super careful around texture. You want to be careful around, work with your speech and language folks if that's necessary, around taking a bite and taking a sip.
Noise around mealtime is just so important to people. And you talked about chatter. I'm thinking, I've been in areas where, in group homes, where the blenders are going to make this pureed food while the television is on, and people are, there's just so much going on. And then you start to see that people aren't eating as much. And they're reacting to the environment that we don't see. And we just get lulled into, that's just the way it is, that's normal.
As people age, decisions about diet may be driven by health and safety-related issues, as well as by preference. You can find more information about diet, nutrition, and safety at mealtime in our webinars, Health Promotion and Aging with IDD, and Dysphagia, Aspiration, and Choking. The links will be at the end of the training. In addition to safety measures previously mentioned, there will be a need for increased monitoring for people facing other risks, such as falls or those with dementia, including Alzheimer's disease. Specific adaptations may include restricting access to unsafe places and extra monitoring for things like turning off the stove. Monitoring or alarms may be needed for people prone to wandering or who are at risk of falling. Reminders and monitoring will likely be needed around taking medications, eating, and other activities of daily living in order to maintain health and safety. Some people with dementia may experience confusion and agitation and will need support to prevent injury to themselves or others. These are just some of the ways to reduce risk. Any adaptations you make will depend on individual needs of people residing in the house or apartment.
Well, I think each house is different. You have to know your physical environment. You have to know what's outside your physical environment. And you have to have the right staffing. You need to really work with your area office around what the expectations are and what you can do. You don't want to, corral people, but you want to give them the space to kind of wander. And if there's a way to kind of create a path that's sort of natural for them to wander and that's helpful.
There's a risk involved with wandering as well, as if they wander out of the house. And certainly we have gone through human rights and had to put alarms on doors. And even sometimes to have different sounding alarms on different doors. Because alarms, people, again, you get that alarm
Satiation.
Yes, and you don't hear it anymore. So it's really important for staff to be aware of that.
I think you need to be very careful around what their medical status is and knowing what those issues are. So some people may have less of a tolerance for temperature change, and you want to be able to manage that. You want to be careful if it's raining out. You want to know, how to manage a fall risk.
There are bed alarms to alert staff if somebody is gotten out of bed. There are wheelchair alarms if someone is trying to get out of the wheelchair, and that would be a safety or a fall risk. There are mats that can be purchased to put alongside the bed, so if someone does try to get out of the bed and fall, they won't injure themselves. You can purchase beds that are lower to the ground. Or even remove part of the legs to bring that bed lower so the fall won't be as great. And skin integrity is a very big issue, especially when people are aging. They're confined to a bed, they're confined to a wheelchair, they may be incontinent. Incontinent leads to diapers. So you're not necessarily toileting people, you are, but there's also, you have to be aware of changing diapers frequently. Which people sometimes forget to do. So there's almost a diaper schedule, if you will, is important.
People who are nearing the end of life and those who are very frail will likely need extra supports, not just to the environment, but with staffing changes and support and teaching for both staff and even housemates. Those people who are extremely ill and bedridden may require hospital beds and oxygen tanks and other medical equipment not typically found in a home. Residences will need to create space for extra equipment and provide training to those responsible for caring for the person in this environment. Programs will likely need increased staffing, and everyone will have to learn to accommodate outside caregivers, hospice workers, or home health aides, for example. Your local area office, as well as quality enhancement, may have input on case-specific modifications. Ask about the possibility of simulated fire drills and discuss safety plans. You may need to redo the Emergency Service Plan, or ESP. At the end of life, staff must consider the different types of needs that the person may require. From pain management to spiritual care, staff need to assess the appropriate supports for the person as well as family, housemates, and themselves. End-of-life care plans and medical orders such as Do Not Resuscitate or DNR, or Massachusetts Orders for Life-Sustaining Treatment forms, or MOLST forms, must be clearly documented and accessible for all caregivers who must know and understand what and where they are. Ongoing discussions with all staff members caring for the individual must try to support and accommodate staff concerns, including the very real fear that the person may die during their shift. Palliative and hospice support and services have the resources to address these changing needs. The DDS area office nurses can be a resource to assist in accessing their services. This should be a team process. Area office nurses and staff will work closely with the individual, family, guardian, and provider. Be aware that each agency will have its own procedures, so in addition to complying with the DDS policy on end of life and any other DDS policies that may apply, staff need to understand any procedures and policies specific to their agency. Remember that there are others who will be impacted. Peers at home and at work may experience a range of emotions, and their relationship with their housemate may change. They may also need to deal with environmental changes, such as medical equipment in the home and the presence of outside care providers. Fear that they too may become ill and die may present in other individuals and may result in changes in their behavior. To help housemates understand and deal with their changing feelings, be as open as possible and listen to their fears and concerns. Encourage them to continue to interact with the dying individual as much as that person can and wants social visits. Your own behavior serves as a model. In addition, ask housemates and peers what would make them feel more comfortable dealing with the experience. And finally, ensure that peers continue to live their own lives and support their activities and routines.
And I think it's really important to think about bringing hospice in and what it means to the whole team in the whole house. We talk to everybody else who lives there and let them know what's going on. And we've had probably the most important and meaningful experiences with housemates. So as people are really close to dying, you'll find people just wandering in and sitting quietly. And you know, we've had people in really behavioral homes get very, it's kind of a universal experience. Just people go, they sit, they might hold somebody's hand, they might just talk, or just sit there. We've had people roll in a wheelchair and just wait, just kind of let people know that they're there with them. It's really beautiful to watch.
In addition to supporting housemates, staff will need support from each other and from supervisors. Keep open communication through meetings in which clear explanations are given about the person's illness or condition and about their care, including when and if hospice is brought in. Supervisors and management may need to increase their presence to offer support. And as we've said before, be aware that every agency will have its own procedures, so in addition to complying with the DDS policies, staff need to understand the procedures and policies specific to their agency.
Had to sit with providers, and train them and get them on board with hospice, because it's still in this day and age, especially I think also with this population, providers, and I'm talking doctors, nurse practitioners, they don't want to talk hospice. You know, they want to wait until the very end and then talk about it, which is certainly a disservice to the people. So we actually bring it up earlier rather than waiting for one of them to bring it up. And we've had now, oh gosh, probably 25, 30 people on hospice. And some people, you know, it was the best thing, and other people, it was too late. Other people do well on hospice and graduate out of it because of all the care and attention to it. So we no longer are shocked when we start talking about hospice with people.
But you have to get your staff engaged early. They have to know, because you need to know where they're coming from, so that you can support your staff, because they can't support your people unless they're supported.
And we've had staff who have said, I can't do this.
Yep.
And
And you
then
need to give
they're
them that
transferred
opportunity.
to another site.
Yeah. It's really important to get the entire team, including your area office, engaged, because there are huge implications there. And the family, if the family's involved, a lot of times it changes the environment for everybody. So when somebody's dying, as in any of our homes or any of our families, more family come in, so people are in and out a whole lot more. That changes other dynamics, and you have to think about what it means for the other people living there, and you still have work to do for that group. But you need to let that happen, because that's important. So,
And that training and that introduction doesn't just happen once.
No.
It's a constant,
Yeah.
especially with attrition of staff,
Mhm.
you know, and you can have relief staff. That training has to be ongoing all the time.
I will say that every time we've introduced hospice into a new house, there's always that trepidation, and then after the death, we have never had anybody say, we'll do it another way.
Right.
We would rather have done it a different way. It's always that was a
Mhm.
positive experience.
When caring for aging people, there will be additional staffing needs. People who no longer attend day program will be at home during the day. When staff are caring for a very frail or dying individual, there may be requests for time off and extra assistance on overnight shifts. An agency will need to budget for this. Ongoing communication with the area office is important. Supervisors and management leaders at agencies may need to increase their presence in the home, especially as they model ways in which to comfort someone who is very ill or who is nearing the end of life, as well as how to help housemates and peers understand and cope with the situation. In addition, management staff should support and assist staff with reporting a death to the area office, and they should be sensitive to the emotions of staff who were present at the time of death.
Staff work with these folks day in and day out, and when they die, it's a huge impact on staff. So if you can plan to have the on-call person or somebody in the chain be able to do some of the paperwork, the compliance, you have to report to DPPC, you have to report to DDS, you have to make all these, just kind of paper things that just feel so almost like an insult to injury when somebody dies, because the staff really need to grieve, and you want to support your staff to grieve.
Finally, remember that the people you're caring for have connections to many places. Some may be attending programs even through serious illness. Make sure you communicate across all settings through meetings, written communication such as logs and emails, and informal communication about concerns. Make sure that everyone caring for someone with changing medical needs is aware of all medical orders, including end-of-life orders. This webinar is one of a series of webinars on adapting to age-related changes in the home, day program, and community, all of which can be accessed at our website or through the Massachusetts Department of Developmental Services. This training was produced by the Center for Developmental Disabilities Evaluation and Research on behalf of the Department of Developmental Services. Thank you for watching. Please visit our webpage for more trainings in the series on aging in people with intellectual and developmental disability.